All right, so week 7, let's go ahead and let's go right to that PowerPoint. And I sent you the PowerPoint and I sent you, of course, always a study guide. Know that this week I will be giving you all the stuff that you need for your exam. Make sure you go over that dosage calculation. Those dosage calculation forms I send are not crazy things. They are the questions from your exam. They're worded a little differently, but the numbers are different, but it's the same sort of questions you'll see. So if you can practice them, guess what? You will understand what you need to do, the steps that need to be done. All right. So the child with blood or blood forming organs problems, let's start with the lymphatic system. Well, what's a lymph system? Well, what the lymph system makes stuff that helps fight infections. That's the one thing that you really need to understand about it, okay? It drains that lymph nodes, its infectious organisms are destroyed. White cells killing these things, and antibodies are made. So once you get an infection on a virus or this or that, your body builds up the antibodies, and that's where it's stored, okay? Now, lymphoadenopathy. An adenopathy or opathy, like myopathy is a big heart or muscle, right? Cardiomyopathy, lymphadenopathy, an enlarged lymph node, okay? That's all it means. And when lymph nodes are big on kids, they're sick. Because guess what? You don't feel them if they're not sick, okay? And in the neck, it could be in the armpits, it could be in the groins. And the spleen is one of the largest organs of the lymph system. It helps makes blood and it helps, store those antibodies, etc. So one of the things that can happen also is an enlargement of the spleen. So enlargement is called a splenomegaly. It's not an apathy, it's an egaly, So cardiomegaly, cardiomyopathy are two are the words that we use interchangeably. So what happens is lymphatic systems get bigger when something's going on. It's an infection, it's something that's acquired. Sometimes it's anemias, and sometimes the liver's not working, and that's your lymph system. Now, blood. Blood is red, and yes, it carries red blood cells, but there's more of it. There's liquid that flows these cells around, and that's called plasma. Okay? Inside the plasma, that liquid is erythrocytes, leukocytes, and thrombocytes. What's that? Well, erythrocytes are your red blood cells. They carry oxygen and iron to the body, right? Leukocytes are what fights infection. These are your white blood cells, okay? And where do these get formed? Well, in the lymphatic system. And they put it into the blood, and then it helps the body fight whatever it needs to fight. And thrombocytes are platelets. Platelets have everything to do with bleeding. You don't have enough platelets, you're going to bleed, okay? So we do look at thrombocytes for the platelet counts in a simple CBC, and it will show us if you have a tendency towards bleeding. Usually, platelet counts are about 100,000. When it starts to get to there, it's about 20,000 when you're bleeding. Now, anemia. What is anemia? Well, something happens for whatever reason, and you don't have enough red blood cells. Well, let's look at that logically. Red blood cells carry oxygen and iron food to the cells. You don't have enough oxygen and food going to the body. What's going to happen? You have no energy, you have no food, you have no oxygen. So you're going to be pale, you're going to be weak. Your body's going to try to breathe more to get oxygen, but you don't have red blood cells. It's not going to carry it around. So you're short of breath. And then the heart's working hard, 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 trying to get oxygen around, and it can't. And then they go into congestive heart failure. So in a child, they say hemoglobin below 8 is what we are concerned about. So it's all about oxygen and iron go into the cells. If it doesn't get enough, body tries hard, but then it could lead into the failure, the shortness of breath, congestive failure. The most common nutritional deficiency is iron deficient anemia. I'm sure some of you have it or know somebody who has it. It just means there's not enough iron in the body. It could be due to many different things. We know that children, especially toddlers, are more apt to be iron deficient anemic because they don't eat all that good green leafy vegetables, right? And they don't eat as much. They're very picky eaters. Also, what if we don't give formula or we don't give breast milk up to that 1 year of age? Well, that infant's not getting iron. And that can also lead to iron deficient anemia because breast milk and iron fortified formula is carrying all that iron to you, right? It also can be a problem with bleeding. Of course, you're losing cells, or something happens, iron can't be, given to the body, or, you're growing too big, or you're not eating enough. All of those things can cause it. So, what would you see in a child that has iron deficient anemia? Well, they're not going to be as active as a normal child. They're gonna be trying to save their energy, okay? They're gonna be pale. They don't have that red blood cells. They're gonna be irritable and they're gonna be hungry. And they're gonna say, I'm hungry, but they're anorexic. They don't want to eat. Why? They don't have the energy to eat. They're just absolutely overly exhausted. Now, what do we look at in this sort of thing? Well, we're gonna do a simple CBC. We're going to look at the red blood cells. We're going to look at the hemoglobin and hematocrit. And we're going to look, of course, what does cells look like? Are they the normal shape? Because other stuff can cause anemia, like what? Sickle cell, right? So we're going to look at those cells. And they're going to test for iron. They can do iron levels, seeing is it where it should be or is it too low? And we could treat that in many different ways, right? Now, remember, the one thing we always rule out with low hemoglobins and hematocrits is some sort of bleeding. And one of the things that we tend to forget is there's a lot of issues with GI bleeds. So let's rule out a possibility of a causative reason. Is it because of I'm bleeding in my GI tract? So check a stool for occult blood. If it's negative, then this is something else that's going on. Then, of course, we're going to look at the type of cells. We're going to look at iron concentrations and say, it's iron deficient anemia. So if we let this go, hemoglobin hematocrit, whatever anemia it is, as I said, that heart's going to work really hard trying to get oxygen and get iron and nutrients to the body, and it's working overload. Also, they're tachypnic, they're breathing. So these children many a times go into heart failure. The heart muscle becomes too weak, doesn't work, and because they're not getting nutrition, what happens? You don't get nutrition. Cognitively, they're not going to be where they should be. All right. And they're going to be short. They're not going to be that normal size. I mean, it's one of the reasons why every visit to a doctor's office, we do a height and a weight. ER, urgent care, doctor office. Children, you're getting a height and weight. Adults, they don't care anymore. We're already at our normal height. So it's not going to tell us as much, okay? So how do we treat iron deficient anemia? Number one, we can try nutrition, increasing the iron in the diet. But many children, when it gets to the point where they're iron deficient anemia, they need more than that. They need a supplement. Remember, there is iron and it's a liquid. This is the one in pharmacology that you were taught drink through a straw. Why? It stains teeth. Now, we give it before meals because the acid in the stomach breaks it down and makes it usable for the body. We also take it with orange juice because that's also acid. That also helps in the absorption. The vitamin C is what that's talking about. and never ever with milk and before meals, empty stomach. We want those gastric acid to really break down the iron and make it work. So, other sorts of anemia, sickle cell anemia, I mentioned it. And what's the difference here? Well, it's not nutritional. What this is a problem with the shape of the cells. And that picture up top there really shows it. It's like a little sickle or like a little C, okay? And the hemoglobin and hematic and RBCs, they're normal usually, okay? Now, what happens? Now, when you have a trait, you're not going to have those sickle cell attacks or crises, as they call them, okay? But when you start getting sickle cell anemia and it's showing some sort of, attacks, sickle cell crisis, it now is you have the disease. It's not a trait anymore. Remember, you need two parents with a trait to get a child. 25% chance we'll have sickle cell. Now, what are you going to see with sickle cell? Well, sometimes all of a sudden you start to see is swelling in the fingers, the toes, or some area gets swollen. And what happens is that these cells get stuck in the blood system. Our vessels go from big ones and bifurcate into smaller ones and into bifurcate into smaller vessels. And when it splits up, it gets stuck. And then once a cell sticks it and then other cells can't get through, they back up. And then the blood, is backing up, it's swelling and it's causing pain and swelling and, ischemia to wherever it's at, whether it's in the chest, in the organ, in the eye, in the brain, in the heart, anywhere this can occur. So it's that impaired circulation because blood can't get through and they're stuck in there, they're clumping, and then it leads to, blood's not getting where it should be. Now, usually hemoglobins in sickle cells are low. These cells die quicker, okay? So, hemoglobin's low, what do you expect? This is a child that normally is going to tire easily. There's no oxygen, there's no iron, there's no nutrition. So this child's pale, tires easily, and really doesn't want to eat. Same sort of thing I was talking about. So sickle cell crises, when these children come in, could be almost anywhere. Could be a chest, could be, think about, it could be in the brain too. So remember, if you're having a headache with sickle cell, be worried about a stroke impending, right? That would be a severe one. Chest one could be a severe one. Many a times it's in the abdomen, it's in an arm, it's in a leg, it's in a wrist. And you can see it swollen and it's hot and it's painful. Usually what precipitates or before this happens, this child has a fever. So with these children, they are taught if they have a temperature of 100.5 or higher, they need to call the doctor. They need to be placed on antibiotics. They're immunosuppressed and they don't have backup. So they need to be, and remember, fever burns up fluid. Those vessels are getting smaller and those cells are going to be able to clump up easier and create more pain, more pain, more pain. So you could go to fever, vomiting, it's in the kidneys, hematuria, convulsions, the brain, the neck, coma. All of these things can occur. And as I said, a risk for stroke, headache, children, sickle cell, big danger, danger. So types of sickle cell, there's vaso-occlusive, where again, that's what I'm talking about, the pain. The splenic sequestration, it's into the spleen, and now it's causing that to swell. Aplastic crisis, which is an aplastic type anemia, and then hyperhemolytic, which is all of these cells are bursting in there. So why does this happen? Well, the biggest reason is dehydration. And then you have decreased blood oxygen because oxygen's not getting around. And dehydration is usually due to infection. And many times you'll see children, especially those teenagers, they're going through these exams, getting ready to go to school, into colleges, and they're concerned, all that emotional stress that can cause and trigger a sickle cell. Also, think about it. Why an exposure to cold? What happens to the cells and your vessels when it's cold? And you put cold on it, it constricts. What happens to those vessels? They get smaller than they already are. And guess what happens? It leads to more block up, cells can't get through, and there's another crisis. So, thalassemia is a condition where I call these actually rectangular shaped cells. And what happens with them is they burst quickly. So they're a short life and they burst. And what happens when they burst? Oxygen is gone and the iron is gone. So there are a couple types that we categorize here. There's a minor, which, it happens a little bit, but you can live with it. Your body will produce enough cells. Then there's Cooley's anemia. Cooley's anemia is when so many cells are bursting all the time, and the cells that are produced are still, quickly bursting, and you're getting iron saturated your body, and it's toxic from your own cells, and it requires transfusions to live. This is usually Mediterranean descendant. So it's an X or female hormone, which is hemophilia. So a bleeding problem. That means you cut yourself. Normally, you hold pressure on it, the bleeding stops, right? Well, when it comes to hemophilia, there's something wrong, and you bleed, 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 and it comes from mommy. It's the X chromosome, okay? They do look at this um, when you're pregnant with your child to try to rule it out. Now, there's a couple different types of hemophilia. There's hemophilia B, it's factor 9. Now, hemophilia A, most common of it, and that's factor 8. And remember, these children, you've got to be careful um, that they don't cut themselves, that they have a nice, safe environment, right? Especially if they're like a toddler, you find out they have hemophilia, you got to look at your house. Is there areas where they can scrape against a coffee table or something and they could cut themselves? Because a toddler is going to do it if they absolutely can. So we need to make sure that the house is safe. Now, what do we do with hemophilia? Well, when a child comes in and we're suspecting this, and they usually show symptoms like usually nosebleeds or a lot of hematomas, ecchymotic areas in the body, and this kid, no, the kid doesn't go out and play, doesn't fall, whatever. They do a blood test, and what they find out is that PTT, a bleeding coagulopathy thing. Remember, there's a PT and a PTT. PTT is really prolonged. Like the normal level is 40 and it's like 200, 300, 400. It could be really, really, really high. So hemophilia is the absence of something that you need to clot blood, factor 8, factor 9, and that makes that child more apt to bleed longer. Now, as I said, sometimes it could be diagnosed at birth, but sometimes it's going to be later on that we're, looking at it, that we're seeing, the kids bleeding. And it's usually later on in life, okay? Now, usually it can be diagnosed at birth. Factor 8 it go into the fetus, but we're not really aware that this child has this hemophilia. But what if you're a boy? You get a circumcision, it's going to bleed, 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 and then you're going to say, "Oh, there's something that's going on here," right? Usually blood clots in 3 to 6 minutes, and in hemophilia, it can take up to a 1 hour or longer. Okay? Now, anemia, leukocytosis, and an increase in platelets can be seen in hemorrhaging, right? So low blood count, and then the white blood cells are trying to work here. And then there is all of a sudden you're bleeding into your urine. And because of all this bleeding and volume depletion, you can death can occur from it. And again, remember, hemophilia bleeding, you could have bumped your head, you're bleeding inside your brain. Symptoms could be just a headache and vomiting and disorientation. And it's telling you that I bled inside my brain. So again, it's trying to think of these things. Now, ITP, immunothrombocytopenia purpura, ITP. P is about platelets, okay? Platelets are another thing that aids in clotting. Now, usually we start to see these issues somewhere ages 2 to 4. And you know how we've found them? Usually it's after some sort of history of an upper respiratory, some infection that's gone on. Usually that's like 2 to 4 weeks before, okay? And then all of a sudden, this child is going to be all of a sudden bruising, petechiae, those little purple purpura type of rashes on them. And you know what they usually come in with? Nosebleeds. And this is the third in 2 weeks. Not just the first one, but multiple ecchymosis, epistaxis, bleeding out of the nose, okay? So that is the things that you would see. And as I said, platelet count should be 100,000 or more. I mean, 100,000 is low, but it's usually below 20,000. So once we see platelets that low, we are going to do a bone marrow. We're going to look at platelets and see what's going on with it. So our treatment always with any bleeding coagulopathy thing, you see me keep telling you about the brain. Always be concerned. Headaches, bleeding problems, concerned about the brain, all right? Neuro checks, very important, okay? Now, usually what we do for ITP, that immune thrombocytopenia purpura, is that we're going to give them steroids, prednisone, IVIG, and anti-D. It's different sort of elixirs that boost the immune system. Now, this says a splenectomy might be needed. I've never seen that. Usually, just this treatment takes care of it. But what we need to teach our patients and our families is anything that can cause the blood to thin, like aspirin or phenylbutazone, phenycetine, caffeine, all of those can thin blood. We say, please, avoid them. And while these child are with low platelet counts, this is a child that you don't want them out running around playing football, getting bruised, and tackling kids because they're just going to make more bleeding to go on. Okay. Now you would say, well, why don't we just give a dose of platelets? Wouldn't that help? No. You have to correct the body's reason why there's no platelets. You can give platelets, but it doesn't really work with this at all. So bleeding disorders, what is our concerns? Well, GI bleeding, checking stools for occult blood, absolutely. Hemoarthrosis, and this is one of the big things even with hemophilia. Fall down, you hit your knee, and you're bleeding inside your knee joint. And it can destroy the joint and cause crippling later on, okay? As I've said again, the third, fourth time, intracranial hemorrhage. Be careful of the brains. And some of the times, how do we prevent like an ITB caused by a viral illness? Immunize your child. The flu shot, the COVID shot, all of the RSV shots, whatever those immunizations are, anything for viral, get those injections. Now, disorders of white blood cells. Well, when you think of white blood cells, what are they? Well, white blood cells are that thing in the body that fights infections for you. And what happens is leukemias that like to attack either the lymphoid or the myelogenous cells, so ALL or AML of the white blood cells. There's different sorts of them. And it destroys them. It makes them non-functional. So what happens with this is these children will all of a sudden their hemoglobin hematocrit going to drop because cancer is going to eat those red blood cells also. White blood cells, what's the normal range? What, 7 to 10,000? It could be 0.1, could be their level. So no immune system here. Okay. Then you're bleeding, bruising, tired, achy, and usually pain in the joints is what we usually see with it. And they don't feel good. And of course, those lymph nodes infection, they don't feel good. Lymph nodes are trying. They're all swollen. And as I said, because it's leukemia in the blood, it's not only just affecting white blood cells, it affects the red blood cells, your hemoglobin hematocrit. It then can go, if we leave it go on and not treat it, it will attack the liver and the spleen. Of course, if it's in the liver, you're going to go jaundice, turn that yellowish color. Again, it's bleeding, coagulopathies with this, petechiae and purpura, ecchymotic areas, bruising, all of this is part of it. And they don't feel well. They're tired. They have no energy. So they're anorexic. They're not eating. They're vomiting. They're losing weight. And, even though red blood cells are low with oxygen, so they're trying to breathe and they can't get oxygen. So how would you diagnose it? I had a next door neighbor who went into the ER and she actually had ALL and she had the symptoms I said. She was pale, she was tired, she ached everywhere, her knee was hurting, she had a fever, she just felt horrible. She had bruising and she didn't go out and play and wasn't falling down. She went in and she was an ALL with a zero point 0.1 white blood cells. That was the history. When they did she went into the ER, they did a CBC and they saw what was going on and looked at the cells there. And then, once they determine it's ALL, they're going to do x-rays. Let's look at what's going on with the bones and what's happening to the body. And of course, the spinal tap. Is it in the spinal column, in the spinal fluid? And we'll always look at the kidney and liver functions because we're going to give chemotherapy. And chemotherapy is very toxic. So we want those body metabolism excretion, right? Everything's metabolized in the liver and it's excreted through the kidney. So we want to make sure they're good. Now we'll give sometimes radiation if we know where to hit it, but usually it's chemotherapy. And what they do is a couple stages of chemo. Induction is actually the most intense of all the chemotherapy. They could hit them with 2 or 3 types of chemo, and usually at the end of induction, 4 to 6 weeks, their cells are eradicated. They're in remission, but they don't stop there. They're going to go for into the spinal column, a maintenance, a reduction. They're going to make sure all the cells were gotten because they're going to sneak and hide places. So we do it longer than just that initial 4 to 6 weeks. They will be given steroids. It helps them in many different ways, but what are side effects of steroids? Well, if you're on steroids, you don't know if you have an infection or not, right? It masks those signs. You also will gain fluid with that also. I mean, what's not mentioned here, even high blood sugars when you're on steroids, right? All of those things go on with that. Chemotherapy. Well, when we think of chemo, we think of vomiting, don't we? They're always, part of that. You're on chemo and, you're worried about the vomiting. There's nausea, vomiting, diarrhea, rash, the hair. on many of the children, they do lose it. And as I said, they will be anemic. The blood cells are killed also. And then, of course, that bone marrow, those where all the cells are being formed, everything is suppressed. One of the things is peripheral neuropathy. What is peripheral neuropathy? It's when the nerves are desensitized and become almost to the point of painful. It tingles. I mean, many different diseases have it, but sometimes it has to do with child's not eating well, kid is pain, we're giving pain medicine, and now they're constipated. And it has to do with the nerves from the low spine going down. So you see a lot in those low extremities. One of the treatments, if chemo doesn't work, is a bone marrow transplant. So kids with leukemia, you know, I know that I visited my next door neighbor and her mother quite frequently, and she would talk to me because was her neighbor. Now they were Korean, so they don't talk to people. They're very private, but I was a neighbor, and we had gotten very close with our kids all the years. For many years, we lived next to each other. So I would let her talk, let the mother talk, and it helped her a lot. Today, she's a PhD in psychology. I mean, she's fine, and this is many years ago, but she did really well with it. As a nurse, what is your concern? Well, looking for infections, because remember, there's no white blood cells. They're on prednisone. They're not going to be showing you signs, but we're going to be watching them for having a temperature. And if we do, getting antibiotics started very, very quickly. We're also going to be looking for things like the platelet counts are low now. It's going to eat platelets too, red bloods, white blood cells. Do they need blood transfusions? Do they need platelets? This is the one that's going to get those bags of platelets or blood cells, whatever they need. And they always oral from mouth to anus. The whole thing can get all swollen up. So great mouth care, great skin care for these children. Now, Hodgkin's lymphoma, what I call this, it's a house. It's a lodge. A lodge is from your shoulders up, and that's when you see those neck with those big lymph nodes hanging out. Ever see a kid with one that's big that just has maybe, adenoiditis or something? But in Hodgkin's, it all will be up, and it's going to press against the trachea. Okay. Okay. So that is called Hodgkin's lymphemia. It's that lymph node, okay? So what do they do to diagnose it? Well, they're going to be doing a biopsy. And in the biopsy, they're going to find Ring Sternberg cells, okay? Now, it's usually after 5 years old, it's usually early adolescent. This is not younger kids, it's older kids, and it's more in boys than it is girls. Now, if we have those big, and I said it's above the shoulders, it's the neck with these big lymph nodes. They're going to do radiation, try to shrink it up, get rid of it, and then give chemo for it. And usually they do really well with it. And you can see long term is really fine. One of the problems with getting radiation and chemo the way they do it, some of these children become sterile, which means they can't either father a child or the woman can't have a child, okay? And again, we know you talk about radiation, it is exhausting on the body. So you're going to see malaise, being tired, being irritable, they're anorexic. And we need to, as nurses, make sure that we don't try to do too much at once. Give the child frequent rest periods. So when they're doing radiation, make sure that they're protecting it, especially me in South Florida, making sure the sunlight don't get on it because it can burn it, just sunlight there. Um, the one thing that we think is they've had radiation, they're going to be, glowing in the dark and it can hurt the other family. They're not radioactive, okay? And that's one thing that we need to teach the parents and the other children, all right? And sometimes we will see things happen like, puberty speeded up a little bit, with you're going to start seeing them, those sexual characteristics and their menses are coming quicker than normal. So the chronically ill child, a chronic illness, if you can imagine being a kid with chronic problems, let's say your cystic fibrosis, it's for life. They need to have respiratory treatment all the time. They can't eat until they take medicine, right? This is a lot to work with. So remember, these kids can sometimes become a behavior problem. Now, it doesn't mean they're allowed to, all right? But it's understand when they are. Because of those frequent hospitalizations, they feel rejected from their family, some of their brothers and sisters, or brothers and sisters can be mad at him or her from getting all the attention when they're always sick, right? And, the thing with nurses, we tend to be that one person that can help them. Because what do? We give shots, we put blood pressure cuffs on, we do all of this painful things, right? So making sure that we, number one, teach them what's going on, and then like on some of the hospitals where I've worked, especially like the cancer floors, what they do is when they're 10, they'll put adolescents together in a room and they can talk about what's happening with each other. And it sort of makes it like I'm not the only one. This is how I feel, you feel. And it does help them. And as nurses, we need to encourage that. They can't get with somebody else, because of their condition and they're so immunosuppressed. Well, then sometimes it's us. And these children do speak with us. Children with developmental disabilities. Now, remember, just because they have disabilities doesn't mean that they can be bad and not do the right thing, right? They still need to have that routine and the structure and a code of what ethics, the way that they're supposed to act, okay? That's very important, all right? And then what about developmental disabilities, a Downs girl going into puberty? They need to know what is a proper code of sexual conduct, what is a proper touch, who's supposed to touch them, and what do they do when something happens, okay? And these are real concerns. Children who are chronically ill, we need to not look at what they can't do, but what they can do. I was talking to Karen earlier about this CP boy, and I knew him at 7 years old or 6 years old, and nonverbal, spastic CP, but his smile was ear to ear. And I used to always tell him how beautiful his smile was. So encourage the goods. Don't, focus on the bads on them, okay? The family-centered care, very important. Mommies, daddies, brothers, sisters, aunts, uncles, grandma. I'm the one who's always part of the whole thing. All of those things are really important, all right? Children should be treated as normally as they possibly can. Don't try to hold them back. So integrate them into what's going on in community. If they can go out and play, go swimming, let them swim. But again, do it within what they're able to do. Okay. So focus on trying to get them into life and treating them as, quote, normal as we can. Now, the dying child, a discussion question of yours, all about um, when a kid dies. Now, I've had many a child. Many of my patients have died. Some have died in my watch. Some have died when I wasn't there. But, remember, nurses go through this too. But, it's also remember the family. So the way I view death is different the way that you view death, that a family does. Give them the opportunity to do what they need to do if, a child dies. If they need to have a priest, a minister, a rabbi, a medicine man, whatever, come, they've died, and they need time alone to do whatever it is they need, we need to allow that, all right? Another thing is a child who's dying may ask you, especially older children, and yes, I'll always start with, so you think you're dying? It's always that therapeutic communication that we're taught, right? But again, honesty, and telling the child that you're going to try to make them as comfortable as you can. And then sometimes I've even cried with kids. I've cried with parents. And you know something? There's nothing wrong with that because we are human just like they are human, right? So showing the compassion, right? And non-judgmental. If this is what they need to do, let them do it. They need to cut hair, take it. They want handprints, fingerprints. They want whatever, don't judge them. This is the way they're dealing with this, okay? So be sensitive with them during this time of it, and then try to keep communication open. Let the family talk, let the child talk. It does help them cope. If you need to bring in that minister, the rabbi, the whoever, or just, the social worker up to talk, whatever it is, give them all the resources we can. So cognitive cognitive development rather than chronological age. You have children that are 5 that act like 20-year-olds, right? So again, we need to know where that child is and that understanding. Children younger than 5, they're just worried about not being with mommy, daddy, or their brother or sister. Okay? And then preschool children, they are fantasizing of what death might be. All right. And then they say that children do not really understand concept of death till about 9 or 10 years old. So what are you going to see when a child's going to be dying? Well, they're going to, of course, slowly lose their consciousness to the point where they're not going to respond. You're going to see capillary refill go down. Their heart's not going to work well. You're going to see them getting discolored. You're going to see it. They're not breathing as deep. There's no energy left. They're giving up. So the lungs are going to have some serious sounds in them, and you might not see them moving anymore. And now the GI child with a GI condition. There's a lot of GI conditions that you don't see in adults. This, I think, is the most of all of the body systems, is the one that is the most different from adults to children. So, GI system, mouth to anus and everything in between. All right. It's basically you eat, goes in the stomach, it starts to absorb it, goes to the body, and it helps the child grow. When you have failure to thrive, this is a child for some reason doesn't absorb the food, can't metabolize it, or is not eating the way it should. FTT, failure to thrive. I've seen a few of these in my life, where the kids are 8 months old and still 12 pounds. And they're like, the kid was born at 7 pounds. The kid should be a lot bigger by then. Pruritus, itching, is a lot of times, think about liver. Liver and itching go hand in hand, okay? And symptoms of GI problems, well, pain in the tummy, vomiting, diarrhea, constipation, rectal bleeding, and vomiting blood or anything else. Now, a disorder that can be done is something called an esophageal atresia or a tracheal esophageal fistula. These are two types, all right? Esophageal atresia is the mouth goes down to the esophagus, but it doesn't connect to the stomach. So there's no connection to the stomach. A tracheal esophageal fistula is when there's a tube or a connection between the esophagus and the trachea. So they eat, food goes across that tube into the lungs. Can you imagine that? So there are four types they talk about. Esophageal atresia is just that there's nothing there. They're going to eat and it's going to come right back up because it's nowhere to go. Then you again have the one with the trachea and the esophagus attached. You're going to see this child gagging and choking because they're aspirating, aspirating, aspirating. An imperforated anus. You were taught in maternity, one of the first things we do is to take a rectal temperature on the baby, right? Because you want an accurate rectal temp, right? Nope, you're checking to see if there's an anus there. I've seen one, and I've been 25 or more years in pediatrics and newborn. I've never, just not once seen it. And there's no connection. So the baby, if they eat, food goes down, it doesn't go anywhere. So what they have to do with this one is they're going to need to immediately put in a colostomy, or sometimes they can stretch it out and reconnect, but they start making an anus, and it's multi step to do that. But if you don't put in a colostomy, where's all that stool going to? There's no exit point at it, okay? Now, pyloric stenosis, very common. I've seen, 100 of them at least. These are children. It's usually about 2 weeks, 3 weeks, up to 3 months, and the sweet spot is 7, 8 weeks age. And this is a child who eats and all of a sudden vomits across the room, projectile, because it goes down and then gets in the stomach, and that little sphincter that connects it to the small intestines is closed. The pyloric stenosis, it's closed. So that is a big thing. Now, we do surgery, they fix it, they do well. It's not a big deal. But it is higher in boys than girls. It's really, really scary. Can you imagine bringing in a 7, 8 week old baby vomiting projectile across the room and you tell them, well, you need surgery? It is scary. So, celiac disease. This is something with the small intestines. And we don't see it until we start introducing the cereals, the wheat, the barley, the rye, the oats, all right? Now, rice cereal, remember it's the most allergenic of all? It doesn't happen there. Rice is great. So when they start going to the barley and the oat cereal, these children are going to have a really abdominal pain, cramping, and they're going to be having a diarrhea with it. It has to do with the celiac in the small intestines, and it doesn't absorb all the food. So classic is just that. The atypical is now when it's just mild, but you start to see things like that peripheral nerve, remember constipation, that nerves, that pain in the legs, and you're going to see that child complaining of their legs hurting. Sometimes it's silent and we just find it out just because the child doesn't really show any symptoms of it. And then latent, it's sometimes just a rash, and it could be just with wheat. So celiac disease, we treat it by not giving this child wheat, barley, oats, or rye. Corn is fine, dairy is fine, vegetables, fruits, and rice. Okay, this you have to be careful with macaroni and cheese and chicken nuggets, that toddler's favorite food, right? They can't have it. So it have to be rice noodles and rice flour on the chicken McNuggets, making your own, because the regular bread will hurt them. Now, Hirschsprungs. Hirschsprung's is basically a ganglionic megacolon. Wow, what a word, right? Well, aganglionic means there's no nerve feeling in the lower descending bowel. Okay? And that lower descending bowel, the food or just mucus, normal liquids go down and it stretches and it gets really big and it doesn't hurt because there's no nerves there. What would you see with a Hirschsprung disease child? Well, if you see that picture way down in the bottom, you see that big outpatching, and then there's like a little tiny little opening on the bottom. It's like a little bit of stool will get out, and it looks like ribbon. Looks like came out a little frosting thing for a cake, and it's like a little bit of ribbon there. Okay, so more with boys and Down's children. You know, Down's children, there's quite a few things, but this is another one. Usually, what you see, and the symptom is in a newborn, you're going to see no stools or just that little ribbon stool within the first day or two of life. And they'll do an x-ray and they'll figure it out. You're going to see as they get older, if we missed it, you're going to see that constipation. Again, abdominal distension. It's going to, not failure to thrive type thing that's not absorbing because remember, no nerves, it's no peristalsis. It's not absorbing anything. Okay. And these children, they have to take it out, that piece. Sometimes they have to do a colostomy, and sometimes they can take the bottom and hook it back up. It's called a pull through. But again, that useless piece of intestines must be taken out. All right. So it's written here what we do. Again, newborns not stooling. That's one of the things that we're going to be checking for. Children that has constipation, young ones, will be checking their abdomens to make sure we didn't miss one, or maybe it was a small Hirschsprung's. And the other thing is when they're not absorbing nutrients the way that they should, then again, we're going to be checking their abdomen, making sure that their intestines is good. Well, here's another one with children. When we talk about intussusception, it is a child where the intestines all of a sudden sucks up into each other like a telescope, just like that. And what you see is all of a sudden this kid is screaming, abdominal cavity is tense, and their legs are going. And these are usually what I've seen 2, 3, 4 year olds. And then all of a sudden it will pop out and the kid's running around like nothing ever happened. Now, if it stays in there and it can't come out, we'll do an ultrasound and we'll find it. And what we try to do is do an enema, or sometimes we call it an air embola. We try to push it out, and that's done in radiology with a radiologist with fluoroscopy. And sometimes it could push it out and it will correct. But sometimes if it's left there too long, the intestines has died. And then, of course, surgery, they have to take out that piece. And then, not a colostomy, just take out that piece of intestines. Now, Meckel diverticulum is basically a little inside of the usually small intestines. There is an outpatching inside and it tears, and there's a blood vessel in that little tear, that little piece of tissue, and it bleeds. And that all you would see with this is some bleeding. And they can go in again, find out, and they could remove that little piece of diverticulum, it's called. So let's talk about things like inflammation of the stomach and the intestines. Well, we think about that as GI issues, right? Colitis is the colon. Enterocolitis is more than just the low colon, it's the small intestines and the colon. Why do we get GI problems, gastroenteritis? Well, sometimes they got into something that was bad and that creates it. Most of the time, we're going to see things like food intolerance. This is one of the things I tell you when they become 6 months that we're watching them one food at a time every 4 to 7 days. We're going to check, is it all of a sudden every time we give them peas, all of a sudden, they're get diarrhea, something to look at. Also, overfeeding can cause children to have diarrhea. It's just too much. What if the formula wasn't prepared correctly? And then there's sorbitol, which is in some meds, etc., that we might see. So, one of the biggest concerns, and it hurts children, is dehydration. Dehydration can create all the way to the point of total organ failure. Dehydration is extremely serious in children. So priority in children with diarrhea, vomiting, they're dehydrated, is to get fluid and electrolytes in them as soon as we can. Now, sometimes we can go oral, sometimes it's IV, sometimes it's both. It all depends on the doctor. But the goal is to get the fluid back in there. So what do we need to monitor? We're giving fluids, we're replacing the fluid that's lost, accurate intake and output. Diapers are important because usually they come in, they're no wet diapers because they're dehydrated. We start giving them fluids orally and IV, whichever way, and now they're starting to put out urine. We want to see that, right? And then, of course, keeping the child warm. With dehydration, you have all of the fluid tries to go to the core, to all of the organs, and your hands and feet don't get as much blood, right? So cold hands, cold feet, let's keep them in a blanket, let's keep them warm. And that's why, okay? And then as nurses, you have a child with diarrhea, make sure that you're using gloves, proper hand hygiene, right? Also, safe food handling, storage, and just keeping bedsides clean, children clean, and infection prevention. And that's always hand washing using those alcohol things. So, problems with vomiting. Hold on. All right. What happens with vomiting is the stomach can't hold something down and you're vomiting. Remember, what happens with vomiting? You're losing acid and you keep
Potassium
losing.
too.
Well, absolutely. Potassium
And
is the fluid.
electrolytes. Yeah.
Electrolytes, yes.
Absolutely. So we know that if we let that go, we're losing acid. The acid base balance is going to change to alkalosis, and that can cause death. Again, dehydration, fluid loss, again, serious, serious, serious. So, biggest thing is that causes it is feeding them wrong or leaving the formula out or the breast milk or, you know, leaving food, not, washing your hands or prepping food for the family, not washing hands, feeding the baby, all of those things. We don't want to, but it does happen, all right? And know that things, systemic illnesses, remember vomiting is always with neurological things. You got to be careful. Did they fall down now vomiting? An infant can't tell you their head hurts, they have a headache, but they'll show you by vomiting, right? And know that children, all of them, no matter what, when they eat, especially babies, all of them are prone for aspiration pneumonia. Why do you think we will burp our children, right? Why do we encourage them to sit in a chair for 30 minutes after a bottle of breast? It's because we're worried about aspiration. Now, lower esophagus sphincter sometimes is relaxed, and sometimes we have what we call reflux, gastroesophageal reflux, probably one of the most common things we see. You know, I can literally hold an infant that's having reflux and tell you the kid's having reflux. You will see that kid arch their back because it's going up their esophagus and it burns, and we know all about it. We know that children that have delays, especially neuromuscular delays, Down syndrome, cerebral palsy. A lot of them, you'll see all that reflux. Again, diarrhea, sudden, it's getting rid of it. We've gone over a lot of it. Just know that diarrhea could be not just, what I said, food, etc., but virus, bacterial, or it could be parasitic. I mean, what if you were out of the country or somebody out of the country came to the house? I mean, so many things can cause it. So we have to usually rule out all of these things on children. Constipation, this is one of those things that parents, suffer from. And I'm telling you, I've seen kids go 7 to 10 days with no bowel movement. Can you imagine 3 and 4 year olds, 10-month-olds, where you take an x-ray of their abdomen and the whole, ascending, transverse, descending colon are white and full of stool? And the problem, with it is initially we just got to get rid of it. Yes, we'll give them an enema, but we don't give enemas all the time. We do not give laxatives all the time. Okay. We need to find out what's going on, change diets. Um, they have a type of Miralax that they call it for children. It's about the only increases fiber in their diet. It's about all they do. Children can have diarrhea, fluids going around that constipation area and coming out. That could be, or they could have constipation and then they have their soiling and they don't know. So they're all of a sudden their underwears are getting stool in them. These are things to look at, okay? Again, fluid electrolyte imbalances. We know that this is a real serious thing. We know that we need to replace it as soon as we can. Respirations loses a lot of fluid. Fevers lose a lot of fluids. So making sure that we know those signs of what dehydration are. What would you look for in dehydration? An elevated heart rate, right?
Dry mucosal membranes,
Dry mucosal
skin
membranes,
turgor, skin
or
tunting,
skin
sorry.
turgor, like
Yeah,
tenting,
turgor,
yes.
yeah.
No urine output, poor capillary refill, right? The elevated heart rate is always number one and no fever. There's a problem. Is it pain or is it fluid? Very easily we can check it. Very good. So dehydration, there's many ways. It's isotonic, hypotonic, hypertonic. And hypotonic, we need to put something back in there. Sometimes there need to be more sodium. Hypertonic means there's too much. So it's just the type of solutions that we're going to give to that child in order for them to get their body back to where it should be. But again, we're always looking at potassium, sodium, and then giving them the fluids. Now, overhydration. You can overhydrate anybody? Yes, you can. What's the problem with too much input and not enough output? Well, where does that fluid go? Well, it can go interstitially. It can go into the, the lungs. It can go into the brain, causing extra pressure. So we really don't want to give too much fluid here, okay? One of the things that happens with fluid, and your body's dependent, is on protein. Protein has to be at a good level, or it messes up with fluid in the cell and extracellular. Okay. Now, anasarca is the term where you are edematous head to toe, everywhere. You swell up, neck, face, everything. Eyelids, you should see them. They puff up quite a bit. Now, failure to thrive is when they're not gaining weight and they're staying right there. Like I said, that 10-pound, 8-month-old child was still one of the last children I saw in the ER. Failure to thrive. Was it due to something about the kid? Well, for instance, a congenital heart defect child whose heart is working faster and more than a normal child's going to burn calories. So they need more calories or they're going to not gain weight. That is a given. Or what if they don't have, they're absorbing the nutrients? I mean, maybe we had to take out that big piece of bowel. That could cause problems with nutrition. Now, again, you don't get nutrition, development will always be delayed. You have to feed the brain, or cognitively, they're not going to be on those developmental markers. Okay. So one of the things, that we need to look at with failure to thrive is, that environmental issue, the parents, the social, are they are they at home? Are they homeless? I mean, those things do make a big deal. Those things, stress, the mother, breastfeeding, stress, not going to have enough milk, all of those things we need to look at. And of course, always look at any child at birth, that mom and baby just don't connect, that bonding doesn't occur. Kwashiorkor is a deficiency of protein. I mean, we don't really see this here. This is usually in developing countries that we see it. I always used to remember it's only in Africa, but it's in many other places than that. And again, it's protein deficient. This is where they don't have protein that they can eat, and they only have grain or vegetables or whatever, but there's no protein. I mean, protein helps with healing and everything, doesn't it? Rickets, not enough vitamin D. I mean, we get vitamin D just through the sun, and that's really all we do need. But some children don't get that. And rickets affects bones. So the legs will get bowed, or the knock knees, or you're just going to see teeth wrong. And it's all because of deficiency of vitamin D. It's why we give breast milk, we give vitamin D. It's one of the reasons here to prevent it. And that's why we say going out 20 minutes a day with a child, a baby, that sun is good for them. It's the vitamin D, right? And we know that we can give supplements if we need to stop them from being in rickets. Scurvy, not enough C. I used to think about this with the pirate ships a long time ago. They get scurvy and they realized they had to bring oranges on their ships. I remember this from school many years ago. And scurvy has to do joint pain, bleeding gums, loose teeth, no energy. And we know that vitamin supplements and just giving them citrus fruits and raw leafy vegetables. Hernias, has anybody ever seen a belly button or an umbilical hernia that you can push in and out? It's sticking out. It's soft and it's squishy. Oh, I love playing with
Yes,
those
I
things.
saw one. Yes.
I love playing with those things in and out, in
Me
and out.
too. Me
It
too.
is it is not a problem in and out, okay? It's when you try to push it in and it's hard and it's swollen and painful that it needs surgery because it's turning and it's losing oxygen. But I love playing with those little ones. Now, inguinal, I've seen a lot of those in the newborn ICU on little males that were preemie, small preemies with the coughing and whatnot, and they would get these hernias and they all can be fixed. Okay, it's not an emergency unless it's hard, swollen, and painful. So, an appendix, most common of all the GI surgeries, isn't it? I think that this is that little piece between the small intestines and the large intestines at the cecum. It's this thing that all of a sudden, right lower quadrant pain, and you'll see these kids. You can, if you ever work in an ER, have the opportunity, or doctor's office, they're walking in, they're bent over, their hand is down on their right lower quadrant, and they're limping on the right leg. It's an appendix. So we need to go ahead and remove it. If all of a sudden that pain stops, it's ruptured. And that's more of a post-op thing. We hopeful So we don't get that peritonitis and septicemia that will require IV antibiotics. Now, oral thrush. I see this a lot on newborns, right? The little infants, that white tongue that you're trying to scrape it off. You think it's milk, but it's candida. It's a yeast. Now, it hurts and it burns. And that's why these children become anorexic, okay? So what we do is we take the nystatin, that little lotion, with a swab, we wipe it on their tongue, and that's all we need to do. And then make sure if we're bottle feeding that we do clean those nipples, those bottles well. If we're breastfeeding, making sure that we do clean the breast and the nipples before that child, can breastfeed. Worms. This is that kid at night who's going crazy and itching and like, at nighttime. And it's usually when it bothers them the most. These worms come out at night and they tickle around the anus area. So the Scotch tape test. Parents are taught at night, go in with a flashlight and take a piece of Scotch tape and put it down over their anus and then pull it up. And you'll see these tiny little eggs or sometimes itsy bitsy little worms there. And then put it in a jar, a baggie, whatever, and bring it in. And then they will give medications to take care of it. Again, one person has worms, you better check the whole household. Poisoning, it's a big thing in kids. Everything in their mouth, right? Explore the world. Do you know what they ate the most? Children, everything. Flintstones vitamins was the biggest thing that I've seen. That and chewable Tylenols. That's dangerous because they taste good. Now, what is the goal? What do we do? Well, if we're, teaching it, if you see any poisons, it should, of course, be put up properly, but immediately take it away from them, call poison control first. And every parent should have 1-800-222-1222 programmed in their phone. If they suspect any sort of poisoning, call. We never, ever induce vomiting. Epicac, we don't do. And you know why? The potential of aspiration or burning the esophagus with whatever they did. I've seen them do grandma's heart pills. I've seen rat poison. Of course, those Tide balls, I've seen a few of those things, but mostly Flintstone vitamins. And as nurses, I've worked closely with infection control. Lead poisoning. When I think of lead poisoning, I think about being in a city, older buildings that have windows with windowsills. And kids go up to it and look out the window and they're teething and they're biting on the windowsill. And if the paint that's in that windowsill has lead, you can have lead poisoning. Okay. Some kids like to eat weird things, plaster, I mean, all sorts of things around the house. That is called pica. And some kids do it. Remember, any child who's doing these sort of things, it does create central nervous system issues and it's permanent. And again, it can cause mental retardation. So, something parents should be aware of. Foreign bodies. You know what the biggest foreign body I've seen? Quarters. They love to swallow quarters. Not a dime, not a penny, even not a nickel. And they're always stuck right here. And you'll get an x-ray with that quarter right there. Now, most of them I've seen, they're breathing when they come in. Even with that stuck there, they do the x-ray. And what they do is sometimes they swallow it and then we let it come out. And we'll tell them to come back in a day or two and have an x-ray to make sure it's gone. Um, but sometimes we can take, and the surgeon will put a catheter, just a Foley catheter, down the mouth, blow up the balloon and pull it, and it will bring up the quarter. And usually they're sitting on that doctor's lap. Right in the ER, they do it, and they do actually tolerate that well. A lot of stuff, huh? A lot of stuff today. I want to answer a question here. All right. Who wants to do a cahoots and who wants to win today? Anybody?
Coops.
Okay, Jessica. Lauren, you can do it. I know you can. Angela, come on, you got to beat her.
Professor, I have to go get my daughter in like 4 minutes.
All
So
right. Remember, sign
I'm
out.
able to do the
Sign
cahoots.
out.
Or
Sign out and listen
okay,
to the recording, okay? That's your best
okay,
bet. Thank you, Angela. I appreciate that. Really do. Thank you.
okay. I'll switch her days from now on, Professor. So she'll have to give me Wednesday, and I'll just
Okay.
take her another day when I'm free.
All right.
Okay.
Appreciate it. Oh, there's more than three of you here tonight.
My internet's still acting up, Miss Bogart. I'm gonna still try to do the cahoots. That's why I had got out of there without getting out of there. It knocked me out. It's storming over here.
Yeah, I saw what you put. Peanut butter. Where's the jelly? Nobody's jelly today? All right, we'll get going. Week 7, chapters 27, 28. Which finding in a newborn is suggestive of tracheoesophageal fistula? That's that little tube that connects the trachea and the esophagus. Remember, if they swallow down the esophagus and there's a connection, where is some of that food, milk, going to go? Into the lungs. Even just swallowing mucus, you're going to see choking, gagging, cyanosis, and that is the clue. This isn't always diagnosed before they're born. So that choking on first feeding is that clue. And as nurses, we're the one who's going to see it. A child's been vomiting for the past 2 days. What acid base imbalance would the nurse expect? Well, you vomit stomach acid. What is left? And all you have left is alkalosis. So, vomiting, you vomit acid, okay? You're left with alkalosis. Diarrhea, all of your nutritional enzymes are alkaline. So, diarrhea, you're losing alkaline. What is left? Acidosis. Those are two common acid-based questions you'll see. Hereditary blood disorder, the body does not produce enough adult hemoglobin. Hereditary. Adult hemoglobin, it's not right. And that is thalassemia. Sickle cell is irregular shaped cells, okay? But they say thalassemia is not enough adult hemoglobin. Why are rapid respirations a possible cause for dehydration? Remember I told you fevers burn fluids, that could be a chance of dehydration, and respirations, and why? It's because your mucus is moist in your mouth, and that breathing in and out dries it out, and it causes fluid loss. Very simple. What would the nurse expect the parents to report of an infant with pyloric stenosis? That's the 7 week to 3 month old infant. And you have that little pyloric valve, it's kinked, and fluid body can't go down into the intestines. And it's that all of a sudden, poof, I'm talking across the room, 15 feet away, and I'm not exaggerating. It is quite impressive how far they can vomit. A multi. How would you treat chronic constipation in children? How do you treat it in adults? So, just like adults, add more raw vegetables, not cooked. Cooked will take out the fiber and, of course, increase in the fluids. If you add high iron food, just like iron supplements, it causes constipation, okay? So that's why it's the other two. A child's been scratching the anal area and complaining of itching. What does the nurse suspect? Remember, that's the Scotch tape test, isn't it? And it's called pinworms. How do we prevent pinworms? They say, well, kids are going to go outside, play in the dirt, sandboxes, and all of that. And that's where this stuff is, keeping the nails short on children and hand washing. What instruction will the nurse give to parents about preventing the spread of reinfection of pinworms? So, this is all about keeping their nails short. It's as simple as that. Which food would the nurse recommend to include in the child's diet who is constipated frequently? How do you prevent constipation? What are the things we do? Well, of course, we're going to give extra fluid. We've already said that. And we're going to put whole grain cereal. It's fiber. Fiber will help. Yogurt adds those probiotics. It doesn't help with really constipation, okay? What condition is characterized by pain in the right lower quadrant at the McBurney's point? Rebound tenderness. And that is appendicitis. So you have a child that comes in, right lower quadrant pain, rebound tenderness. What's the first thing you should tell that child? Do not eat or drink anything from now on. Okay. That's the most important thing. This child will be going to surgery as soon as they can because we don't want it to rupture. Because if it ruptures, it causes peritonitis, which is a really serious infection. Description of a child's stool characteristic leads the nurse to suspect intussusception. So when that child comes in to the ER and we think the intestines had sucked in like a telescope and their abdomen's hard, their legs are kicking and their arms and they're crying, I will always look at their underwear or into their diaper. And there is like, it's like currant jelly. It's almost clear with maybe a little streak of blood in it. And it is currant jelly. Very good. What does a nurse expect the appearance of stools of a child with celiac disease to be? Remember, this is the gluten intolerance. And it's called bulky and frothy because it's not being um, absorbed. It's not being, the body's not using it. It's just full of it, and it's like almost like beer froth. You can almost call it. You would see it in a diaper if they were wearing a diaper. A 7-month-old infant admitted with a diagnosis of acute gastroenteritis. What would be the nurse's priority goal? What did I tell you about gastroenteritis, GI problems, vomiting, diarrhea? What's our biggest concern here? I mean, we're lucky a 7-month-old infant. We still have a fontanelle. We can still see if it's sunken. That would be dehydrated. That's probably the best age to determine it. But yes, you don't want that fluid to get too low. And of course, the electrolytes prevent fluid electrolyte imbalance. Very good. After surgery for pyloric stenosis, an infant's hungry and crying. What is the most appropriate nursing action? So just go in and they stretch the valve out. Really simply, they cut it, open it, so now that there's a valve, that the food can go into the stomach. Infants, do we keep them NPO a really long time? No. And the reason is they don't hold sugar all of that long. So what we'll do is, well, we say it like a clear liquid, and we want glucose because they don't hold sugar, okay? So 1 ounce, small amounts, and maybe every hour, every 2 hours, just enough to soothe that child's hunger. They even say today, maybe breast milk. They consider that a clear liquid, believe it or not. 1 ounce, smaller amounts of it. A multi. Child's brought into the ER suspecting appendicitis. What are the signs and symptoms? So it's rebound tenderness, okay? Guarding, not necessarily. It's more rebound tenderness. And then if you take and lift that right leg up, it's going to hurt. Many physicians go up to the bottom of their right foot and they hit it. And the child, they'll feel it right into that right lower quadrant. What statement by a mother may indicate a cause for her 9-month-old's iron deficient anemia? Remember, I told you one of the biggest things in iron deficient anemia are the toddlers, right? Toddlers don't eat as much. Now, this is a 9-month-old. Why isn't that child getting iron? It's because they're not giving formula or breast milk, right? They switch it to whole milk and it's too early. Not yet. What is the most common nutritional deficiency in children? Iron deficient anemia. Children, adults, doesn't matter. That is the most common. Hereditary blood disorder that the red blood cells are in a crescent shape. Sickle cell anemia. Yes. What regulates how many red blood cells are produced? Red blood cells. If we look at this, we look at leukocytes and neutrophils. It's all about white blood cells. You didn't pick them. Erythropoietin is in the kidneys, right? And it helps produce red blood cells. It's the erythrocytes. Is also another name for red blood cells. So erythropoietin in the kidneys, it helps the body produces red blood cells. We can also give that in injections if for kidney disease or other things that are going on. We sometimes do it with leukemia, giving them those injections to make the body still produce its own instead of getting transfusions. What information should the nurse include in a teaching plan about home care for a child with hemophilia A? So with hemophilia A, we're all worried about bleeding. And remember I told you they could fall down, hit their knee, bleed inside a joint, and really destroy those joint sacs. And now you have a child who could be crippled in a wheelchair later on in life. So if we're seeing bleeding going on in something like an elbow or a finger or something, apply the pressure. It's rice at this point. Pressure, ice, elevate, and rest, right? Rest, ice, contain, and elevate. That's all what we're supposed to do there. What will the nurse teach the parents of a child with low platelet count to avoid? What does a low platelet count mean for a child or an adult? This is, we're talking about ITP, or we're talking about leukemia could have low platelet counts. We're worried about bleeding. Low platelets equal bleeding. So which one of these increase bleeding? Aspirin. A child with leukemia has widespread purpura and a platelet count of 19,000. What is a nursing priority? Low count, low platelet count, and now you're seeing purpura and um, what do you think's going on here? We are now concerned about things like neurological status, right? Remember the brain, because you can always bleed in there. And again, they have platelet counts here on bleeding precautions. You're not going to be sticking these children with extra IM injections or anything. And we're going to monitor them. Are they bleeding anywhere else? But the head and neurological status is most important. Which statement indicates an understanding of health maintenance of a child with sickle cell disease? What causes a sickle cell crisis? That's the bottom line to what this question's asking. And remember, sickle cell disease is caused by the vessels are too narrow and sickle cells can't get through. And it creates the backup and it creates the pain and all of that. So drink plenty of fluids. What if you're in cold weather? Wear warm clothes. And you know where else that we have to be concerned about it? They go up in an airplane. The compression of, that inside the airplane, drinking more fluids before going in a plane. All of those things are some teaching that I've taught parents. Most common cause of anemia in children? Iron deficient anemia. Absolutely. What is a complication of repeated blood transfusions? A child with thalassemia major. Cooley's anemia. Remember, they live on blood transfusions. There's no other treatment really to do with it. They're saying maybe a bone marrow transplant, whatnot, but this is something that's for life. what happens when you're getting blood transfusion? It's called hemospherosis, and it also has to do with getting extra antigens in the body and becoming a really hard blood type. All of those things are the complications, and usually can't getting the blood they need is what is cause of death on many of these children. Hereditary condition where the blood does not clot normally. Yep, hemophilia. Good. A recent blood count for a child who received chemotherapy shows neutropenia. It's a priority nursing diagnosis. What are we worried about with neutropenia? Like, what does that mean? What are neutrophils? Where do they come from? They're white blood cells. You don't have enough white blood cells, you are at risk for infection. What's the priority nursing action? Hand washing, as simple as that. What type of cells carry oxygen and carbon dioxide in the blood? It's erythrocytes. Erythrocytes are also another name for red blood cells. Platelets only have to do with bleeding. It's part of the cascade of what you need to stop bleeding. Okay. What can occur? What can occur? Iron deficiency anemia goes untreated. So you have iron deficient anemia and you've got this low blood count. What can happen? Remember, when you don't have enough red blood cells, oxygen in the body, what does the body do? The heart speeds up, right? And it's heart failure because the heart's working and working and working and it's not getting any relief. And finally, it just gives up, basically. A multi. What skin assessments would alert the nurse to bleeding for a child with a low platelet count? So, purpura, petechiae, ecchymosis, anything that's bleeding or bleeding like, very good. Lymphadenopathy, no, that has to do with white blood cells and infection in lymph nodes. What is the name of the malabsorption problem that results in gluten intolerance? Remember to avoid wheat, rye, barley, and oats. And rice is probably that flour. They have all sorts of things like that now. People today are so lucky because it's understood in grocery stores. It's gluten free. Stuff is labeled everywhere today, even potato chips, gluten free. And I'm amazed of how much that has progressed. Last question. Hereditary blood condition where the RBCs are crescent shaped. And yes, sickle cell anemia. Let's see how we did today. Peanut butter. Who has jelly? Jacka. Oh, Jacka, number 2. Woo. A 1512698. Good job.
Woo, that's me.
Karen and Mark. Good job, Vanessa. Woo, that's the first. I like it. I like it. Is
Butter.
just gonna come back
Peanut
next
butter
week and
got to be Paula.
really struggling with it.
What y'all know?
Peanut butter.
Yeah, no, it got to be you.
I absolutely love it.
Professor, I came
Ability
fourth.
to host.
Is that okay?
I think it's awesome. I think everybody
Oh,
who
yeah,
plays
you didn't
wants
say
to do it.
nothing to me. Give me a clap.
I said, whoop, whoop, whoop.
Okay.
Listen, this is my first time I was able to join, and I came in. Listen, peanut butter in the house.
You know, I do these cahoots for this reason, what you're experiencing right now. As we get doing them, it becomes a competition. And not only is it a competition, you're listening and you're understanding. And now I gave you a lecture, and now you're getting that repetition and explaining it a little simpler as it goes, and you'll remember it. And that's why I do cahoots. So good job. Thank you very much. So, everybody, have a great night. I'll be posting this as soon as I can. Remember, next week, our reviews. All right. Of course, it will be, posted like I normally do. And I will see you next week.
Miss
Good luck,
Bogle,
guys.
Night. Thank
I
you.
got a question. Have a good night.
Good night.